Hi, Arundel. This is your Nagraj, NORCET mentor and NORCET guide. In this video note, we're going to deal with the very important topic that is your fluid and electrolytes. If you see, electrolytes is a very important topic for your NORCET 9 prelims, mains, and on your various like central government examinations. If you see in that electrolyte, they're going to specifically asking the hypokalemia and hyperkalemia. They're going to directly hitting a topic, okay, hitting a arrow on the concept called as hyperkalemia and hypokalemia. In this, like specifically, if you speak means they are asking you the ECG changes, in a hypokalemia and hyperkalemia. So in this, we're not going to deal with the MCQ, some theoretical point related to the electrolytes and fluid balance. So without delay, we're going to start the today's session with the beautiful concepts. Okay, before going to the MCQs, I'll teach you some tricks. Okay, some tricks while solving the questions, while solving the test series and all. It'll be very helpful for you. Okay, during examination, when you sit in front of the desk, in front of the computer, okay, in front of a computer-based examination and all, if you sit no, then you should remember the 4 points. Okay, I'll tell you 4 points while solving the questions. Okay, that you should keep in a mind that. Okay, without a delay, we'll go to the today's session. That is a that is fluid and electrolytes. I told you, I'll tell you four terms. Okay, four terms. When you're solving the examination, these four terms are going to help you. Okay, going to help out in a solving the questions when you attend the examination. First terminology is first term is further teaching. Okay, in any long term question, any test series, in any examination, if there is a term, okay, if this term ending with the further teaching means they will give an example, they will give a question, okay, long term question they will give at the last of the question, they will ask you this sentence, okay, this further, okay, further teaching required. So there is a teaching required means you should in our options you should also always choose for the wrong statement. Okay, wrong statement. Where there is a wrong statement, okay, when you're discharging the patient from the hospital, when you are educating the patient in a hospital, when the nursing officer, when a healthcare professionals, okay, or else or treating patient will say wrong statement, that time you should teach furtherly. Okay, you should teach furtherly, or else if the patient is going to ask you some wrong statement, that time that patient require further teaching. You should be clarify that topic, that wrong statement, and you should confirm that, okay, you should give a prompt, genuine answer for the patient when there is a wrong statement is told by the patient or the healthcare providers. There we required the where we require further teaching, where there is a strong statement, where there is a wrong statement, it requires the further teaching. Okay, when you encounter in examinations, wrong statement should be further teaching needed, where there is a further teaching is needed. Okay, we'll go to second question, that is second term, that is questioning. When you'll question in a question in a examination, the question comes, okay, further like where the nursing officer is questioning to doctor. When they return a wrong, when they return a wrong orders, when they return wrong orders, that time you should should ask them why it is written. Just imagine this patient is having a CKD. Is a chronic one patient is a case of chronic kidney disease, and doctor advised you to give a injection KCl. See, just imagine already CKD patient will be having this, so there is so much of retention of potassium will be there, and the further you're going to infuse the potassium means it will cause hyperkalemia. So that time you should ask the question why KCl is needed for this patient. So always keep in mind that when you question the doctor, that they when they written a wrong orders, that time you should question them. And third one, inform healthcare provider. When you're going to inform the like doctor regarding the patient, when there is an abnormality, abnormality in a vitals, or else any abnormal conditions like bleeding, any abnormal bleeding is there, any oozing is there from a surgical site. Okay, this all abnormalities should be informed to the healthcare physician. Fourth one will be documentation. When you document when there is the normal finding, I told you, okay, after surgery, after within 24 hours, like mild fever is acceptable. That you are going to document in a nurse's record. that is not going to inform to the physician or a treating doctor. Document the normal finding. Okay, always document the normal finding. This and all no need to report. When you'll report when there is a abnormal finding. When there is a abnormal finding. Fifth one will be abnormal finding. When there is a abnormal finding, you should report to the treating. Okay, you should report to the treating doctor. These are all the five terms. Okay, it will encounter in a when you're going to attend the examination and going to solve the question. That time you're going to attend this like target is all 5 points. You should remember that when there is a further teaching related means you should always in option you should choose for a wrong statement. When there is questioning terms comes, you should see for the wrong orders. Okay, when you inform the healthcare provider when there is a abnormality, then we have to inform the healthcare patient. Fourth one will be documentation. What will document? Your normal finding to document. A report abnormal finding should be reported to the treating physician. Now we'll move towards the questions. First question of today video note, that is your like in front of you it is there. Just read out. I will read out the question carefully. Just read out the question along with me. The nursing officer, okay, nursing officer caring for a patient with potassium deficit. Okay, potassium deficit. Here the key term that is potassium deficit. Okay, a nursing officer caring for the patient with a potassium deficit means always already potassium is less in the patient body. So the nursing officer reviews the patient record, record nothing but he reviews the patient laboratory finding reports, your CBC report, your serum electrode reports. You're going to see reviews the patient records and it determines that patient is at risk of developing potassium deficit because of patient is what patient is on what. That's why the nursing officer determines. So he predicts that further there is a loss of potassium in his patient. So I should be cautious because hypokalemia is an it's a fatal disease. It's dangerous. Okay, if you not treat the hypokalemia, you will get the patient like a patient will be having arrhythmias will be there and you lose a patient. So you should always read the records of the patient. Okay, you see the investigations, you see the serum electrolytes, you see the CBC reports, and should predict the patient is further will go for deficit or you go for like balancing the electrolytes levels. First, all of you got the questions. I'll read out one more time the question. Nursing officer caring for the patient with a potassium deficit, and the nursing officer reviews the patient records and determines patient is at risk of developing potassium deficit because of what is afraid patient will go for further potassium deficit. Option A is patient is on nasogastric suction. Nasogastric suction, you're going to do the continuous nasogastric suctioning for the patient. That's why he's afraid if further will go for potassium deficit. Option B is on potassium sparing diuretic. Option C is he has a history of renal disease. Option D is a case of Addison's disease. If you see options clearly, like all our GI content, if you see all our GIT content will be rich in potassium. Okay, will be rich in potassium. Your all intestinal juice and your stomach content will be rich in potassium. If you are doing the continuous, okay, if you are doing the continuous nasogastric suctioning, what will happen? There is a loss of, okay, of course there is a loss of potassium. If you see patient records, already patient is having potassium less than 3.5 milliequivalents. Normal potassium level will be 3.5 to 5.1 milliequivalents per liter. That is your normal potassium levels. The nursing officer already saw the patient lab investigation. He's already potassium is less than 3.5 mg deciliters per liters, and he's worried again because we are doing the nasogastric suctioning. There is a chance of potassium loss again further. So that's why this is a right option. Okay, this is a right option. A is a right option. When there is a patient is on nasogastric or orogastric suctioning, he is very prone to get the hypokalemia. So we'll see further like remaining options. We'll see B. Option B is potassium sparing diuretic. If we see potassium sparing diuretic, your aldactone, your spironolactone, or the potassium sparing diuretics. Because if you give the potassium sparing diuretics, there is potassium retention. There is a potassium retention. So there is increased chance of hyperkalemia, not a hypokalemia. So option B is ruled out. Now we'll see option C. Option C, if we see renal disease in CKD and AKI, what will happen? In chronic disease and acute kidney injury, what will happen? Body cannot able to produce the aldosterone. Okay, if the aldosterone is not able to produce, means what will happen? What is the function of aldosterone? It going to retain the sodium chloride and excrete the potassium and H plus ion. Here what will happen? Here opposite will happen. If there is no aldosterone, body will eliminate the sodium chloride. So water and sodium salt will be lost, and there is retention of K plus and H plus. So there is a chance of hyperkalemia, not a hypokalemia. And there is chance of acidosis. That's why here there is no chance of hypokalemia. In case of kidney disease, AK and CKD, there is always a hyperkalemia. We can encounter the hyperkalemia, not a hypokalemia. So option C is ruled out. Now we'll see option D, option number D. That is the case of Addison disease. Okay, Addison disease is nothing but adrenal insufficiency. There is a adrenal insufficiency, means there is reduced adrenal gland hormone synthesis. Mainly, especially we'll see if we see mineralocorticoid also affected. Here there is a less production of mineralocorticoid, nothing but aldosterone. I told you aldosterone main function is sodium and water retention and potassium as potassium and H plus ion excretion. If it is that is not produced in enough quantity, there is a ulta action. There is a ulta action, means body will try to eliminate the excretion of sodium chloride, and there is retention of potassium and H plus ion. So there is a chance of hyperkalemia, not a hypokalemia. So always, if the patient is on NG suctioning or orogastric suction, you should be cautious with the potassium levels. So option number A is a right option. So we'll move to second question. Okay, that is, which of the following ECG finding indicates the presence of hypokalemia? Presence of, I told you, like when I started a session, I told you clearly what is like there. The examiner is going to directly ask the ECG changes in a hypokalemia, hyperkalemia. So potassium is very vital electrolytes which is linked to your cardiac action. Okay, your heart muscles requires a potassium for depolarization and repolarization. So you should always remember, potassium is always associated with the arrhythmias. So ECG and potassium is very related topic. You should be clear with the hyperkalemia, hypokalemia, and what are the ECG is associated with the hypo and hyperkalemias. Now here what the examiner is asking, what the examiner is asking, ECG changes in a hypokalemia. Option number A, tall dented tall peak T waves. Option number B is ST depression. Option C is widening of QRS complex. Option D is PR, prolonged PR interval. If you see, okay, the concept, I will tell you the concept, then you can be able to choose the right answer. The potassium is directly proportional to the T wave. Okay, the potassium is directly proportional to the T wave. Means when there is hyperkalemia, when there is potassium more, so your T wave will be tented, will be peaked. If you can see this is your normal ECG. This is your normal ECG. P wave, Q wave, R wave, S and T. Okay, P, Q, R, ST. This is a normal ECG. When in case of, I told you potassium is directly related to the T wave. Okay, T wave is here and inversely proportional to the U wave. Potassium is, okay, here I will write potassium is directly directly proportional to the T wave and inversely proportional to the U wave. Means when there is hyperkalemia, there is you can able to see prominent T wave and disappearance of U wave. Okay, U wave will not be seen in case of hyperkalemia. Especially if you see basic concept of ECG, T wave is mainly indicating the ventricular repolarization, not a depolarization, ventricular repolarization. In a hyperkalemia, we can able to see a tall tented T waves, tall tented or camel T waves you can able to see, and you can see the ST depression along with the T wave. You can able to see, okay, this S wave will not touch the baseline and it will escalate into the upstroking of the S wave to the T wave. So there is mixture of ventricular depolarization and ventricular depolarization. So there is ST elevation seen in case of hyperkalemia. But here if you see, examiner is asking the changes in hypokalemia. Hypokalemia means less potassium. Less potassium means, okay, there is a T wave. Okay, absence of T wave. T wave will not be there. Here is T wave is there. Normally T wave is there, but in case of hypokalemia, you cannot able to see the T wave. There is flat T wave, or else inverted T wave will be there. Okay, inverted T wave will be there. Inverted means if, along with the S wave will give a attached to the T depression. So there is ST depression. Okay, there is ST depression in a hypokalemia. Along with the T inversion, S wave also will be combined with the T wave. So there is a ST depression. And if you see, widening of QRS is not seen in case of hypokalemia. Normal, what is normal QRS complete duration? What is normal QRS complete duration? If you ask me, means I'll tell you this one: 0.08 to 0.12 second is the normal QRS duration. Normal QRS duration. Then what do you mean by widening of QRS? Widening QRS is means if the QRS complex time is more than 0.12 second, I am calling this one as widening of QRS complex. Mainly this one widening of QRS complex seen in case of ventricular tachyarrhythmias. Ventricular tachyarrhythmias, not in case of hypokalemia. And prolonged option D. So option C also ruled out. We'll rule out. Okay, clearly rule out option number 8. All attended PUX are not seen in case of hypokalemia. It's seen in case of like especially hyperkalemia, not hypokalemia. And option number C, I told you this seen in case of ventricular tachyarrhythmias, not in case of hypokalemia. And option number D, if you see prolonged PR interval, normal PR interval will be 0.2 to normal PR interval. If you see means that is around like PR interval means when starting of the P wave to starting of the QRS complex. We call this one as PR interval. This is will be around 0.02 to 0.12 second. That is your normal PR interval. Okay, that is your normal PR intervals. So normal PR interval will be around 0.12 to 0.12 to 0.20 second. Means that will be around, sorry, normal PR interval will be 0.12 to 0.12 to 0.20 second. Prolonged means if there is more than 0.20 second, if the PR interval is more than 0.20 second, we call that one as prolonged PR interval. Okay, we'll see this one will be seen in case of heart block, primary first degree heart block and second degree heart block, not in case of hypokalemia. So ultimately your option B is a right option. ST depression, you can able to see the ST depression in case of hypokalemia, not all rated PQS and not widening QRS complex and not prolonged PR intervals. PR interval is not at all related to the potassium levels. Okay. Now we'll move to the towards the third question, that is option that is question number 3. A patient with a cardiac history taking a loop diuretics, furosemide nothing but Lasix injection, and came to casualty with a severe muscle weakness, and which lab test should be done at the first. Okay, he's asking you what the lab test you're going to perform in case of severe muscle weakness when the patient is already on furosemide or Lasix loop diuretics. Option number A, we're going to do a serum albumin test. Option number B, you're going to do a serum sodium levels. Option number C, you're going to do a serum hematocrit levels. And option number D, you're going to see a serum potassium levels. So if you see concept behind, okay, if just we'll see some drug action, furosemide. What does furosemide actually will do? If you see, this one is nephron. This one is nephron. Here the urine will going to produce. This one is PCT, proximal convoluted tubule. This one is loop. Okay, this one is loop of Henle. This one is distal convoluted tubule. Especially this all furosemide and Lasix is going to act on the. It is going to act on the loop. Okay, loop of Henle. Loop of Henle. There will be a sodium, potassium, Co-transporter will be there. Co-transporter will be there. Your loop diuretics, your loop diuretic Lasix we're going to block the sodium potassium co-transporter. So there will be diuresis. So if the patient is on furosemide, there is a chance of sodium and potassium depletion. There is a chance of sodium and potassium loss through the urine. So what you want to do? You want to check the serum electrolyte. Serum electrolyte. You want to do a test called as serum electrolyte. Serum electrolyte you want to do. But if they are asking you specifically what you want to check, sodium or potassium, sodium or potassium. If you see, we're going to check the purely. If you want specifically means you should check the serum potassium level. Okay, we should always check the serum potassium level. Why? Why? Because sodium is rich in extracellular. Okay, extracellularly. Okay, it's will be present in extracellularly. Sodium will be rich in a extracellular fluid. Potassium will be rich in inside the cell. We can call cell is a bag of potassium. Cell is a bag of potassium. Potassium will be very rich in inside the cell. So there is more chance of potassium to come out of the loop of Henle. Okay, out of the loop of the Henle cells. So even though sodium will be large in quantity extract the cell, so there is no less chance of sodium depletion. So there is more chance of potassium depletion. So you should always focus on the serum potassium level when the patient is on Lasix or furosemide. Okay, we'll move towards the some theory concept relating to the your fluid and electrolytes.